Okay, let's dive right into our first clinical case. No fluff, just high-yield review for your boards. So picture this. You have an 18-year-old woman in your clinic. For the past year, she's been dealing with hard, lumpy stools. She tells you she has to strain a lot, and she gets these cramps in her left lower quadrant. But here's the kicker. The pain actually gets better after she has a bowel movement. And what's really important, she has absolutely no alarm symptoms, no fever, no weight loss, nothing scary. And all her labs are squeaky clean. So what are you thinking? Well, this history is practically a textbook definition of irritable bowel syndrome with constipation, or IBS-C. Let's just walk through it. She's got the chronic abdominal pain, it's directly related to defecation, and it's tied to a change in her stool. The fact that it's been going on for over a year with zero red flags, that really seals the deal. Okay, but we always have to think about our differential, right? Could it be something like inflammatory bowel disease? Probably not. She doesn't have the classic diarrhea, weight loss, or anemia. What about celiac? You wouldn't typically test for that with this constipation picture. That's more for the diarrhea predominant type. And cancer? At her age, with no alarm bells ringing, it's way down the list. So what's our first move? We start simple: lifestyle and diet changes, plus the trial of soluble fiber, like psyllium. And this is a huge takeaway for your exams. You always start with the basics: lifestyle and soluble fiber. But here's a pro tip. Be careful with insoluble fiber. Like bran, that can actually make bloating worse for these patients, so you want to avoid it. All right, got it? Let's move on to case number 2. So for our second case, we've got a 64-year-old man who's fighting metastatic pancreatic cancer. About 4 weeks after he started a new chemo regimen, he develops this really bad watery diarrhea. We're talking 6 to 8 times a day, and it's even waking him up at night. Super important detail, his stool stendies have already come back negative for C. diff and for any occult blood. This scenario should make a light bulb go off in your head for chemotherapy-related diarrhea. The timing is just perfect, right? It starts right after the chemo, and look at the type of diarrhea. It's what we call secretory. It's watery, there's a lot of it, and it doesn't stop even when he's not eating. That's why he's having it at night. Plus, we've already crossed the biggest infectious mimic, C. diff, off our list. So, what's actually happening here? It's pretty straightforward. The chemotherapy is just toxic to the cells lining the gut. This damage messes everything up, it tanks fluid absorption, and cranks up electrolyte secretion. The results? Water is just pouring into the gut. So management is all about support. We push oral hydration, and we give him something like loperamide to slow everything down. Now, here is your exam pearl. Because chemo patients are immunosuppressed, you absolutely have to rule out an infection, especially C. diff, before you settle on chemo-related diarrhea. Once you've done that, your go-to first-line medication is loperamide. All right, case number 3. A 42-year-old woman comes in. She feels totally fine, completely asymptomatic, but her routine blood work shows some pretty high liver enzymes that just won't come down. Her AST is 452 and her ALT is 512. Now, here's a really interesting clue. Her total protein is way up at 11.2, but her albumin is normal. And her other liver markers like ALK Phos and Bili are also normal. The giant, flashing clue here is something called the gamma gap, and it's pointing us straight toward autoimmune hepatitis. First, we see a clear hepatocellular injury pattern, right? High AST and ALT with normal cholestatic markers. But the magic is in that gamma gap. You take the total protein, 11.2, and you subtract the albumin, 4.2. That gives us a gap of 7.0. Anything over 4 is a massive red flag for the hypergammaglobulinemia that we see in autoimmune hepatitis. So let's think about what else it could be. Alcoholic hepatitis? Nah, the AST/ALT ratio is wrong, and the enzymes are a bit too high. Acute viral hepatitis? She has 0 symptoms, and the enzymes aren't quite in the thousands like you'd expect. That specific liver injury pattern, combined with that enormous gamma gap, makes autoimmune hepatitis the #1 suspect. Management? We need to suppress the immune system, starting with prednisone. Please burn this into your brain for your exams. The gamma gap is your secret weapon for this diagnosis. If you see high transaminases and a gamma gap over 4, you should be shouting autoimmune hepatitis from the rooftops. Okay, next up we have a 54-year-old man who lives in a homeless shelter. He comes in with a 3-day history of just feeling awful. Fever, malaise, no appetite. On exam, you notice his liver is enlarged. And then you see his labs, and wow, they are sky high. His AST is almost 2,600 and his ALT is over 4,200. With a story like this, your mind should jump immediately to acute hepatitis A. Why? Well, he's got that classic viral prodrome. His transaminases are just astronomical, way over 1,000. And the most important clue is his social history. He lives in a crowded homeless shelter, a perfect setup for fecal-oral transmission. The key differentiator here is just how high those enzymes are. When you see transaminases in the thousands, you should really only be thinking about a few things. And acute viral hepatitis is at the top of that list, along with maybe an ischemic injury. It helps you rule out things like alcoholic hepatitis, where the LFTs almost never go above 500. So we'll confirm it with the hepatitis A IgM antibody test, and the treatment is simply supportive care. The big takeaway, it's all about connecting the dots. You have the clinical picture, the viral symptoms, and the crazy high LFTs, and you connect it to the social history, the risk factor. That's how you lock in this diagnosis. All right, on to case number 5. A 32-year-old woman comes in complaining of these recurrent crampy pains in her rectum. She says each episode only lasts about 5 minutes, and then it's gone completely. It doesn't seem to be related to having a bowel movement or anything else she can pinpoint. And when you examine her, everything, including her rectal and pelvic exams, is totally normal. This is a classic story for proctalgia fugax. It's what we call a functional anorectal disorder. The diagnosis is all in the history. You're looking for these recurrent, super brief episodes of rectal pain that go away completely in between. The absolute key here is that the physical exam is 100% normal. It's a diagnosis of exclusion. We only make it after we're sure there's nothing else going on. So what's causing this? The leading theory is just a random spastic contraction of the anal sphincter muscle. Since the episodes are so short and unpredictable, there really aren't any effective preventative treatments. So the single most important thing you can do for this patient is provide reassurance. Let them know it's a real condition, but it's completely benign and not dangerous. And this is just a perfect example of a board-style question, isn't it? A diagnosis that's made entirely based on a classic history and a completely negative workup. Don't be afraid to land on a diagnosis of exclusion when all the puzzle pieces fit. Okay, our final case. We have a 23-year-old woman with several new male sexual partners. She comes in reporting tenesmus. That's the feeling of having to go, but straining with very little stool coming out. She's also noticed a whitish anal discharge and some itching. When you do a rectal exam, you see a mucopurulent discharge. This collection of symptoms, the tenesmus, the discharge, plus the sexual history, is a slam dunk for a sexually transmitted proctitis. And with that mucopurulent discharge, the most likely bug is gonorrhea, so we're calling this gonococcal proctitis. How do we confirm it? A nucleic acid amplification test, or a NOT, from a rectal swab is the test of choice. And this is mission critical, you do not wait for those results to come back. You treat empirically on the spot. And your treatment has to cover both gonorrhea and chlamydia because they so often travel together. The go-to regimen is ceftriaxone plus doxycycline. And that's our final high-yield pearl. If you have a patient with proctitis symptoms and sexual risk factors, you must treat for both, every time. What's the biggest reason for treatment failure? Forgetting about the co-infection. So don't forget the doxycycline. Nail these cases and you'll be in great shape for your exams.